800 million people take metformin every day. It's the most prescribed diabetes drug on Earth. And for most of them, it works. It's affordable, it's well studied, and it does its job. But there is a group of people for whom this drug can quietly become dangerous. And the worst part, most of them don't know they're in that group. I'm Grace Wells. I've spent years working with older adults navigating kidney disease and diabetes together. And this combination, this specific situation, is one I see go wrong more than almost anything else. So today I want to walk you through exactly what happens when metformin meets a kidney that isn't working the way it used to, what the warning signs are, what the numbers mean, and what you should actually say to your doctor if you're worried. Stay with me, because what I'm about to share in the next few minutes could genuinely change how you think about a medication you may have been taking for years. Let's start with the basics. Metformin works by lowering blood sugar, primarily by telling your liver to stop releasing glucose into the bloodstream when it doesn't need to. It doesn't force your pancreas to produce more insulin. That's actually one of the reasons it's been so popular for so long. It works with your body rather than overriding it. But here's what most people aren't told clearly enough. Metformin exits your body almost entirely through your kidneys. It doesn't get broken down by your liver. It doesn't have an alternative exit. It goes in, it does its job, and then your kidneys filter it out, which is completely fine when your kidneys are working well. But when kidney function starts to decline, which is incredibly common after 60, that filtration slows down, and metformin begins to build up. Not quickly, not dramatically, just quietly. A little more each day. And that buildup is where the danger begins. The condition I need you to understand is called lactic acidosis. I know that sounds clinical, but I want you to understand what's actually happening inside the body because it matters. When metformin accumulates, because the kidneys can't clear it fast enough, it interferes with how your cells produce energy. As a byproduct of that disruption, lactic acid builds up in the blood. Normally, a healthy body neutralizes lactic acid quickly, but when it's building faster than the body can manage, the blood becomes acidic. And acidic blood is something your organs cannot tolerate for long. The heart struggles, the liver struggles. Eventually, the whole system starts to fail. This is lactic acidosis, and it carries a mortality rate, a death rate, that can reach 50% if it's not caught quickly. Now, I need to be very clear here. This is rare. Most people on metformin will never experience this. But for people with significant kidney disease, particularly those whose kidney function has dropped below a certain threshold, the risk becomes real. So let me give you the numbers you actually need to know. The key measurement here is called eGFR, estimated glomerular filtration rate. It's a blood test result. Your doctor runs it as part of a standard metabolic panel, and it tells you how well your kidneys are filtering waste. A healthy young adult typically has an eGFR above 90. By the time we're in our 60s and 70s, many of us are naturally somewhere in the 60s or 70s as well, and that's often considered acceptable. Here is the safety framework that matters. eGFR above 60. Metformin is generally considered safe. eGFR between 45 and 60. This is the zone where your doctor should be paying attention. Some guidelines suggest a reduced dose at this range. Monitoring becomes more important. eGFR between 30 and 45. This is high-risk territory. Many physicians will discontinue metformin here or only continue it with very careful monitoring and an honest conversation about whether the benefit still outweighs the risk. eGFR below 30, metformin should not be used, full stop. The FDA has stated this clearly. The important thing I want you to take from this isn't memorizing the numbers. It's knowing that there is a number and that you should know yours. If you're on metformin and you haven't asked your doctor about your eGFR recently, that conversation needs to happen. And I'm going to give you exactly how to have that conversation before this video ends. Now, here's something that catches a lot of people off guard. Kidney function isn't fixed. It can change. Someone can be perfectly fine on metformin for 10 years with stable kidney function, and then something happens. A bad flu, a urinary tract infection, a few days of not drinking enough water, starting a new blood pressure medication, and their kidney function drops suddenly. The medical term for this is acute kidney injury. And during an acute kidney injury, the risk from metformin spikes dramatically in a very short window. This is why doctors often tell patients to hold their metformin when they're sick, dehydrated, or having any kind of medical procedure, especially imaging scans with contrast dye, which is itself hard on the kidneys. So if you're on metformin and you get a stomach bug that leaves you vomiting or unable to drink fluids for more than 24 hours, this is worth a call to your doctor. Not a panic, just a check-in. Let's talk about what lactic acidosis actually feels like. Because one of the cruelest things about this condition is that the early symptoms can look like a lot of other things. The warning signs include a deep, unusual muscle, aching, or weakness. Not the soreness you get from exercise, but something heavier, something that doesn't make sense. Unusual fatigue, not just tired, heavy. Like your limbs are full of cement. Nausea, vomiting, or stomach pain that seems to come out of nowhere. Difficulty breathing, a feeling of needing more air, breathing faster than normal without exertion. And in more advanced cases, confusion, feeling disoriented, trouble thinking clearly. If you're on metformin and you experience several of these at once, especially the muscle heaviness paired with the breathing changes, that is an emergency room situation. Please don't wait it out. Please don't assume it will pass. Call someone. Go in. A simple blood test in the ER can measure lactic acid levels within minutes. If it's elevated, treatment can begin immediately. Now here is the part of this video I really want you to sit with, because this isn't just about fear. This isn't just about what can go wrong. This is about the fact that if your kidneys have changed, if your eGFR has dropped, there are effective alternatives. Good ones. You don't have to choose between controlling your blood sugar and protecting your kidneys. Let me walk you through the main options that physicians consider for older adults with both diabetes and chronic kidney disease. The first class worth knowing is SGLT2 inhibitors. Medications in this family include empagliflozin, brand name Jardiance, and dapagliflozin, brand name Farxiga. Here's what makes this category remarkable. These drugs don't just control blood sugar. The evidence now shows they actively protect the kidneys and the heart. Multiple major clinical trials, large ones, well-designed ones, have demonstrated that SGLT2 inhibitors slow the progression of chronic kidney disease. So if you have both diabetes and kidney disease, your doctor may actually be able to give you something that addresses both at once. That's not just a trade-off. That's a genuine upgrade. They're not right for everyone. They have their own risks and restrictions. But for many people in this situation, they're now considered first-line treatment. Second, GLP, one-receptor agonists. The name you've likely heard is semaglutide, brand names Ozempic and Wegovy. This class also has emerging evidence for kidney and cardiovascular protection. And of course, they support weight management in a way that can itself reduce the burden on the kidneys. Again, not for everyone. They have a specific set of considerations. But they are a meaningful option that your nephrologist or endocrinologist can evaluate with you. Third, DPP4 inhibitors. Sitagliptin is the most well-known in this class, brand name Januvia. These are generally well tolerated in older adults and can be used in kidney disease with dose adjustments. They're considered a lower risk bridge option for patients who need a straightforward swap from metformin. None of these are a one-size answer. Your situation, your eGFR, your other medications, your cardiovascular history, all of it matters. But I want you to know these options exist because sometimes patients walk into an appointment believing their only choices are keep taking metformin or have uncontrolled blood sugar. That is not the reality, not anymore. Let me talk about monitoring because this is often where the gap is. If you have chronic kidney disease and you're on metformin and are transitioning off of it, your eGFR should be checked every 3 to 6 months, not once a year. Not when you remember, every 3 to 6 months. This is the only way to catch a downward trend before it becomes a crisis. If your doctor is running an annual panel and your kidney function is changing, you can miss a significant drop in function between checks. And that window is where people get into trouble. Ask for your eGFR at your next appointment. Ask what it was at the appointment before that. Ask if you're trending in any direction. Your kidney function is a story told over time. You need to be reading that story. Now, I want to give you exactly what to say to your doctor. Word for word, you can say this. I've been doing some reading about metformin safety in people with reduced kidney function. I know that lactic acidosis is rare, but I want to make sure my eGFR is being monitored regularly and that my current dose is appropriate for where my kidney function is right now. Can we look at my most recent labs together and talk about whether my current treatment plan still makes sense or whether there are alternatives we should consider? That's it. That's the whole conversation starter. You are not accusing anyone of anything. You're not demanding a medication change. You're asking your doctor to look at something specific with you. A good physician will appreciate that question. And if your doctor dismisses it without engaging, that itself is useful information. Before I close, I want to revisit something I said at the very beginning. For most people on metformin, this drug is safe. I don't want you to finish this video and flush your metformin down the toilet. Please don't do that. Uncontrolled blood sugar has its own serious consequences for your kidneys, your eyes, your nerves, and your heart. Stopping any medication abruptly without medical guidance is dangerous. What I want is for you to be informed, to know your eGFR, to understand the threshold, to recognize the warning signs, and to feel equipped to have a real conversation with your doctor. That's the difference between being a patient and being an advocate for yourself, and you deserve to be both. If someone you love is managing diabetes and kidney disease, and you've been quietly worried about a medication they're on, share this with them. Not as an alarm, as information. The people who watch this channel are the ones who ask questions, the ones who don't just nod and walk out of appointments. The ones who go home and actually look things up. That instinct, that impulse to know more, that is what protects you. Keep asking. I'll be here.